Welcome to the Deep Dive. Today we're steering directly into the mind, the highest stakes mental arena in any profession, the mind of the practicing physician. We're talking about clinical decision-making, and you can forget, the amazing technology, the cutting-edge surgical techniques, or the encyclopedic memory for a moment.
Yeah, all that stuff is secondary.
It really is.
Yeah.
Because arguably, a doctor's most critical skill is the ability to synthesize, to reason, and to choose the correct path forward when information is incomplete and the pressure is, incredibly high.
Right.
We are taking a deep dive into the thinking process itself.
And this is a dive that is urgently needed. Because while having vast medical knowledge is absolutely necessary for safe care, research shows us it is simply not sufficient.
It's the starting point, but not the whole journey.
Not at all. Even expert minds are fundamentally prone to error because of the way the human brain is wired. So we are going to analyze the specific science of why those errors happen and, perhaps more importantly for you, the listener, how the best clinicians and the best systems actively correct for these built-in cognitive flaws.
And the scale of this problem is,
Yeah.
it's a staggering, and it often goes underreported. We found estimates that diagnostic error occurs in a significant 10 to 15% of cases.
And that's across major diagnostic specialties. We're talking emergency medicine, internal medicine.
General practice, yeah.
Yeah.
So a huge chunk of medicine.
A huge chunk. And those aren't just minor missteps. This diagnostic error rate is associated with greater morbidity, so greater harm and adverse outcomes, than most other types of medical error combined.
Wow.
The good news, though, is that the majority of these errors are preventable. Understanding the mechanism is really the first step toward prevention.
So when studies analyze these failures, they typically identify three core categories of error. The first one is no fault, meaning the disease presented in a uniquely atypical way, or maybe the information needed to make the diagnosis was genuinely unavailable when the decision had to be made.
Yeah, that's the truly unavoidable stuff. Then there's the second category, which is system error.
Okay.
This is where the fault lies in the environment. So, inadequate diagnostic support, flawed logistical processes, or perhaps most commonly, poor team communication during a critical handover.
That communication piece seems to come up again and again in patient safety.
It's central, but the category that truly tells us the most about how the human brain functions under pressure, and the one we are zeroing in on, is the third one.
Human cognitive error.
Exactly. This is the frustrating scenario where the clinician had all the necessary available information to make the correct diagnosis, but still made the wrong one.
And these cognitive errors are usually the result of what? Knowledge gaps?
Sometimes, yeah.
Yeah.
Knowledge gaps, misinterpretation of complex diagnostic tests, or the superstar of error generation, cognitive biases. You see, clinical reasoning isn't just one step. It's a cyclical process. It begins with the history, moves to the physical exam, necessitates the proper use and, the mathematical interpretation of diagnostic tests.
And then that drives the problem identification and the management plan.
And culminates in shared decision-making with the patient. But the glue that holds that entire cycle together, the thing that separates the merely knowledgeable doctor from the truly expert diagnostician, is metacognition.
Metacognition. That's the ability to think about your own thinking.
Right.
Yeah.
Precisely. It's the constant self-monitoring. It's the recognition that your fast, intuitive brain, while incredibly efficient, is built with flaws. Our mission today is to show you the science behind those flaws and the specific mental tools experts use to override them.
Okay, let's unpack this and start at the absolute foundation. Before we get into any advanced mathematics or the psychology of error, we have to talk about the primary data source, the thing that no technology can truly replace.
The patient history.
The patient history. Despite all the incredible technological leaps, genome sequencing, instantaneous imaging, the history remains the single most important component of safe clinical decision-making.
And that statement is supported by, overwhelming data. Studies consistently show that diagnoses are made from the history alone in a remarkable range of 70 to 90% of cases.
70 to 90%, that's a huge number.
It's massive. The history sets the pre-test probability, which, as we'll discuss, conditions the interpretation of every single test that follows.
And when we talk about history, we don't just mean listening to the patient's story. It's a consultation of all available sources, isn't it?
Exactly. It's a comprehensive data retrieval mission. It means consulting relatives, caregivers, eyewitnesses, if consent allows, of course, and scrutinizing every prior medical note, every paramedic report. It's gathering the full narrative of the illness because the way the story unfolds often contains the highest diagnostic weight.
But simply gathering a long list of symptoms, like a shopping list, is not enough. Our source material stresses that clinicians must practice what's called evidence-based history and examination,
Hmm.
which means you need to know not just a list of symptoms associated with the disease, but the actual diagnostic usefulness or the weight of those features.
This is such a critical distinction. It often marks the gap between, say, a medical student and an experienced practitioner.
Right.
Let's take the classic teaching example of meningitis.
Okay.
Students are universally taught the classical triad: headache, fever, and meningism.
Which includes things like neck stiffness and those Kernig's and Brzezinski's signs.
That's it. That's the memorized list. But the weight those features carry for the actual decision-making process is surprisingly low.
So let's unpack the specifics of that diagnostic weight. One detailed prospective study in the U.S. on adults with meningitis showed that, yes, nearly all patients presented with headache and fever.
Sure, those are very common.
But look at the classical signs. Less than half had visible neck stiffness, and a shockingly small 5% exhibited the textbook classic Kernig's and Brzezinski signs.
5%. So if you're waiting for those signs, you're going to miss 95% of cases. This is precisely why we must translate clinical findings into diagnostic weight. And the tool for that is the likelihood ratio, or LR.
Okay, the LR, remind us what that is.
The LR is essentially a multiplier. It tells you how much a specific finding or the lack of a finding changes the probability of a disease.
So if the LR is greater than 1, the finding increases the probability of the disease. An LR of, say, 10 would be highly significant.
Hugely significant. If the LR is less than 1, the finding decreases the probability. But if the LR is close to 1, say between 0.9 and 1.1,
The finding is effectively useless. It tells you nothing new.
it tells you absolutely nothing. And what that study demonstrated is fascinating. The LRs for those classical signs, Kernig's, Brzezinski's, neutral rigidity, they were all around 1.
So looking for them doesn't really help you decide what to do.
Not for the key decision. And why? Because these are signs of severe, established inflammation, not reliable indicators for the need to perform the critical diagnostic test, which is the lumbar puncture.
Right. So if you wait for the Brzezinski sign, you've probably waited too long.
You've waited way too long. The signs identify inflammation, but they miss the vast majority of early or mild cases, which still require urgent intervention. So the knowledge of the list is irrelevant if you don't know the diagnostic weight. You're wasting precious cognitive energy looking for signs that don't reliably contribute to the core decision.
And this highlights that vital connection to the pretest probability. The LR only tells you how much a single clinical finding modifies the probability.
That's right.
It doesn't determine the initial likelihood. So if the patient is already, rapidly deteriorating high fever, altered consciousness,
Yeah.
your clinical pretest probability of meningitis is already very high.
It's through the roof.
So a finding with an LR of 1 doesn't change the urgent need for treatment and diagnostic intervention.
Exactly. The starting line matters hugely. Our sources underscore that clinicians must incorporate this knowledge about prevalence and diagnostic weight dynamically. And there's an educational insight here, too.
Good.
Students who were explicitly taught the probabilities of features being present rather than just rote memorized lists consistently showed better diagnostic accuracy.
That makes perfect sense.
It does, estimating that initial pretest probability is the intellectual core of the entire diagnostic sequence.
Okay, so once we've done that thorough history and established that crucial pretest probability, the clinician will order tests. And this is where we leave the purely observational world and enter the mathematical world, because we have to utterly destroy the myth that diagnostic tests provide certainty.
That is the second major area where error is endemic: test interpretation. We have to state this emphatically. There is no such thing as a perfect diagnostic test.
No yes or no answer.
Never. They do not deliver a simple yes or no. They deliver probabilities. And those probabilities are affected by 5 factors: how normal is defined, factors other than the disease itself, the operating characteristics of the test, sensitivity and specificity, and crucially, the prevalence of the disease.
Let's start with the definition of normal. When a laboratory gives us a quantitative result, a numerical measure like a kidney function test or a liver enzyme count, they need a cutoff point.
Right.
And conventionally, that normal range is defined statistically as the values encompassing 95% of the general population, so 2 standard deviations above or below the mean.
And here is the profound implication that often creates immense clinical anxiety and subsequent cognitive error. because that reference interval is defined by 95% of the healthy population.
Ah.
It means 5% of healthy people are, by definition, outside that range. 2.5% of healthy people will have values above the reference range, and 2.5% will have values below.
So just by pure statistics, having an abnormal result is highly probable, even if you are perfectly healthy, especially if you get a lot of tests.
Precisely. This is why reference range is the preferred term over normal range. A value outside of it means further investigation is warranted, not that disease is automatically present. The clinical judgment is required to decide if that 5% chance of benign variation is acceptable risk, or if the individual's history overrides the general population statistic.
We also face the persistent overlap problem.
Mm-hmm.
In many common diseases, I'm thinking slight anemia or mildly elevated liver enzymes, the results between the healthy population and the diseased population aren't perfectly separated.
No, they overlap considerably.
So there's a gray area.
A huge gray area. The further away a result is from the reference range, the higher the chance the person has the disease. But that overlap means no single test can provide 100% certainty. It's a continuum, not a binary switch.
And this leads to these fascinating paradoxes.
Mm.
Normal is abnormal, and abnormal is normal. Can you elaborate on the severity, the first one? That sounds particularly dangerous.
The normal is abnormal paradox is incredibly high stakes, particularly in acute critical care. Take, for example, a patient suffering a severe, life-threatening asthma attack.
Okay.
They are fighting for air. Their breathing muscles are tiring. If we measure their PaCO2, that's the partial pressure of carbon dioxide in their blood, the expected finding in severe asthma is a low PaCO2.
Because they're hyperventilating. They're blowing off all their CO2 trying to breathe.
Exactly. But if, in this patient who is struggling desperately, the PaCO2 comes back normal, that is a catastrophe in the making.
Why?
A normal PaCO2 here means the patient's breathing muscles are so fatigued they can no longer maintain their compensatory hyperventilation. They're about to enter respiratory failure. That normal numerical result is the most alarming clinical indicator they could have, demanding immediate aggressive intervention.
Wow. So the context is everything. Conversely, we have abnormal is normal. You mentioned a low ferritin level in a young menstruating woman. In the general population, that might flag potential pathology.
Right, it looks like iron deficiency.
But in that specific context, it might be entirely expected and non-pathologic.
Exactly. And we also have to account for inherent variability. Even if I am perfectly healthy, my lab tests fluctuate daily. This fluctuation includes biological variation, the actual physical change in my body, and laboratory variation.
Which is just inaccuracies inherent to the testing process itself.
Right. So clinicians need to know the critical difference.
The critical difference being the threshold by which a test must have changed before we can confidently say the patient's underlying biological state has actually shifted, rather than it just being random fluctuation.
Correct. For a common test like cholesterol, that critical difference can be as high as 17%. So if your cholesterol drops by 10% after starting a diet, you might be pleased, but clinically that could just be meaningless noise. We need to be aware of the inherent sloppiness in the measurement system.
And then there are non-disease factors that simply distort the results, forcing the clinician to adjust the reference range mentally.
Oh, absolutely. Age is a major one. Creatinine, a measure used for estimating kidney function, is derived from muscle breakdown.
Mm-hmm.
Because older individuals typically have less muscle mass, their baseline creatinine is lower. This means an older person can have a normal creatinine level despite having a significantly reduced estimated GFR, the true measure of kidney function. A doctor relying on the normal reference range for creatinine alone would miss severe renal impairment.
You also mentioned ethnicity, that healthy individuals of African ancestry often have naturally lower white blood cell counts.
Right, which must be taken into account when interpreting potential infection. And pregnancy causes massive physiological shifts.
Like what?
Well, it causes volume expansion, or hemodilution, which can reduce urea and creatinine. It increases alkaline phosphatase because the placenta produces it, and it naturally induces a degree of iron deficiency due to fetal demand. Even the ECG changes, a slight tachycardia, slight left axis deviation, are considered normal physiological responses to pregnancy. Failing to account for these specific contextual shifts leads directly to false positive diagnoses.
And moving to operating characteristics, the test itself is only as good as the conditions it was performed under.
That's a huge one. Think of a test that relies on patient effort, like spirometry for lung function. If the patient has poor technique, the result is invalid. Or an ultrasound, which depends on the skill and expertise of the technician.
So if a report says a scan was technically difficult,
You should be extremely wary if the conclusion is no abnormality detected. It should be reported as non-diagnostic, forcing the clinician to consider alternative imaging. Failing to recognize a non-diagnostic result as incomplete data is a pathway to error.
and then there's the challenge of paroxysmal conditions, like epilepsy, where the activity is intermittent.
Right. Around half of patients who genuinely suffer from epilepsy will have a perfectly normal standard EEG, even if they had a seizure moments before. A normal test does not exclude the diagnosis.
Right.
Furthermore, as testing becomes more sensitive, we generate more incidental findings. We mentioned that 10% of people without epilepsy show epileptiform discharges on their EEG. When you screen large populations with sensitive imaging, you find something that may or may not be relevant to the patient's actual problem. The results must always be subordinated to the patient's story.
This brings us to the famous pair, sensitivity and specificity. Remind us how they inform the diagnosis.
Okay, so sensitivity is the true positive rate. It asks, if you have the disease, how likely is the test to correctly flag you? A highly sensitive test is used for ruling out a diagnosis.
Okay, ruling out. So if it's negative, you can be confident the disease is absent.
Pretty much. And then specificity is the true negative rate. It asks, if you don't have the disease, how likely is the test to correctly clear you? A highly specific test is used for ruling in a diagnosis. If it's positive, you are highly confident in the presence of the disease.
But even a highly sensitive test, say 95%, which sounds excellent, will still miss 1 in 20 people who actually have the disease.
Yes, those are the false negatives. And every test, by definition, generates both false positives and false negatives.
And we often face a trade-off dictated by where we draw the line, right?
Huh.
You mentioned the exercise ECG.
Yes, it's a zero-sum game. If we set a very low threshold for defining an abnormal result, say a 0.5 millimeter ST depression, we achieve high sensitivity. We catch almost every case of coronary artery disease. But we generate many false positives in healthy people. If we shift the cutoff to a more stringent 2.0 millimeter depression, we increase the specificity, fewer false positives, but we risk missing genuine early-stage disease. The choice of where to set that cutoff is itself a calculated decision based on the consequences of a false negative versus a false positive.
The moment we accept that all clinical data, the history findings, the test results are probabilistic, we must confront the concept that ties them all together.
Conditional probability.
Additional probability. This is where we introduce the profound principle articulated mathematically by Bayes' theorem.
Simply put, the theorem states that the interpretation of any piece of new information, like a lab result, depends entirely on what you believed beforehand, the pretest probability. New data does not stand alone. It modifies your prior belief.
Let's make this real with the hip fracture example. We have an older woman who has fallen. She has severe pain, she's unable to bear weight, and she has a history of osteoporosis.
Okay, so clinically, the pretest probability of a hip fracture is extremely high.
Extremely high. She gets an X-ray, which is about 95% sensitive for fractures, and the X-ray comes back normal.
In this high-stakes, high pretest probability scenario, a test with 95% sensitivity that comes back normal does not exclude the fracture. We know that 5% of true fractures might be missed, a false negative. Given the high starting probability, that residual 5% risk is too great to ignore.
So you have to do more.
You must pursue further, more sensitive imaging, like an MRI or a CT scan.
Yeah, let's flip it. Imagine a young, healthy athlete who twists their hip but can still bear some weight. They have low pain, no underlying risk factors. The clinical pretest probability of a fracture is extremely low.
Right, very low.
That same 95% sensitive X-ray comes back normal.
In that case, the normal X-ray virtually does exclude the fracture. The starting probability was so low that even accounting for the 5% chance of a false negative, the post-test probability is negligible. The interpretation shifts entirely based on the initial clinical context.
So while doctors rarely, plug numbers into Bayes' theorem in real time,
No, they don't have a calculator out.
they are constantly applying this principle intuitively. The interpretation of the test is conditional on the patient's pre-existing risk profile.
And this leads us directly to the single most common failure of clinical reasoning, even among experienced physicians: neglecting prevalence. This is the base rate neglect problem, brilliantly illustrated by the Harvard problem.
Listeners, you must pay attention here, because this is the aha moment that often separates feeling informed from truly understanding probabilistic thinking. Let's pose the famous Harvard problem again.
Here's the scenario. A rare disease has a prevalence of 1 in 1,000 people in the population.
Okay, very rare.
A test to detect this disease is highly accurate.
Right.
It has a false positive rate of 5%. We'll assume the test is perfect, otherwise 100% sensitive, so no false negatives. If a person gets a positive result, what is the chance they actually have the disease?
Now, when this problem was posed to a group of Harvard doctors surveyed decades ago, almost half of them, highly intelligent, highly trained experts, they intuitively anchored on the test's accuracy. They saw 5% false positives, 100% sensitivity, and the gut response was 95%.
It feels right, doesn't it?
It feels completely right. But that, astonishingly, is the wrong answer.
And the error is in forgetting the denominator, the prevalence. Let's just break down the math for a population of 1,000 people.
Okay, in 1,000 people, if the prevalence is 1 in 1,000, only one person truly has the disease.
Right.
And because the test is 100% sensitive, that one person tests positive. That is your one true positive.
Okay, now look at the other 999 people who do not have the disease. The test has a 5% false positive rate. 5% of 999 healthy people is approximately 50 people.
50. So these 50 people are perfectly healthy, but they get a false positive result.
Correct. So among everyone who tested positive, you have one person who is genuinely diseased and 50 people who received a false positive. The total number of positive tests is 51.
So the chance that a person with a positive test actually has the disease is only 1 out of 51.
Or roughly 2%.
2%, from 95% down to 2%.
The positive test is far more likely to be a consequence of the test's low specificity interacting with the overwhelming majority of healthy people rather than catching a case of the rare disease. This is why prevalence is the key anchor.
Wow. Even knowing the mechanics, that 2% figure is so counterintuitive. It shows why clinicians must actively work against base rate neglect, especially when testing for rare conditions in low-risk populations.
And this distinction is why we differentiate between predictive values and post-test probability. A predictive value is a snapshot calculated from a specific table of results in a specific population.
So you can't transfer it.
You can't. If you take that value and apply it to a new population with a different prevalence, it breaks down. But post-test probability, calculated using Bayes' principles, can be applied to any patient in any population, provided the clinician makes a sound judgment about the individual's pre-test probability.
So the best approach is to anchor on the prevalence in the patient-specific group and then adjust.
Exactly. Adjust for their unique risk factors and symptoms.
Ultimately, the clinician is dealing with uncertainty all the time. While expressing that uncertainty as a probability is helpful, sometimes knowing the patient's definitive state isn't even necessary.
No, sometimes you just need to know enough to act as if the disease were present. This brings us to the treatment threshold.
Okay.
The required level of diagnostic certainty depends directly on the penalty for being wrong. If the treatment is highly effective and carries a low risk like prescribing a standard course of antibiotics for a suspected UTI, the threshold for intervention is low.
Wow.
You're willing to accept a 10 or 20% uncertainty.
But if the treatment itself is high risk, irreversible, or has low effectiveness, think of starting high-dose chemotherapy for a potentially malignant condition.
Then the clinician absolutely requires a much greater certainty, maybe 95% or higher, before proceeding.
And this threshold idea leads to a core question of efficiency, right? If a diagnostic test won't change the ultimate management.
Then why are you doing it?
Right, if the treatment threshold is already crossed, or the risk is too low to act, we must question the necessity of the test at all.
Test results are simply levers to shift our thinking and our management plan. They are never ends in themselves.
So we've established the math and the framework. Now we get to the psychology. Why are our highly evolved, expert brains inherently prone to these statistical errors, even when we understand the math?
Let's use that puzzle to transition.
The bat and ball puzzle.
The one we posed earlier, where the intuitive answer of 10 pence is wrong and the calculated answer of 5 pence requires effort. It's the perfect illustration of why we make preventable errors.
The intuitive fast answer felt compelling, felt right.
And that's the point. James Reason, the patient safety pioneer, argued that our very propensity for certain errors is the price we pay for the brain's remarkable ability to think quickly and intuitively. If we had to calculate every single decision, we would never function.
This is the foundation of the dual process theory in cognitive psychology, which describes two distinct systems of thought.
First, we have type 1 thinking. This is the intuitive, heuristic, or experiential system. It's fast, automatic, subconscious, and it relies on pattern recognition.
Like an illness script.
Exactly. It's what experts use when they look at a situation and immediately recognize a prototype of the disease they've seen many times. It requires low cognitive effort, which makes it highly efficient, but its reliability is variable and it is highly vulnerable to error.
Then there is type 2 thinking. This is the analytical, systematic, or reflective process. It is slow, deliberate, conscious, and effortful.
Right, it demands high cognitive resources and engages working memory, but it's highly and consistently reliable and therefore much less prone to error.
So in daily life, we exist overwhelmingly in type 1. Thinking about driving to work, tying your shoes, reading a common sign. These are automatic.
They have to be. If you had to use type 2 for every mundane task, you'd be paralyzed.
The problem arises in the clinic because type 1, while necessary for speed, is easily triggered inappropriately, especially when the situation is superficially familiar but functionally complex.
Or, conversely, type 2 processing becomes impaired when the clinician is fatigued or stressed, forcing a reversion back to the error-prone type 1 thinking.
So let's run through the specific dangerous cognitive shortcuts, the biases that hijack type 1 processing in a clinical setting, starting with anchoring.
Oh, anchoring is a huge one. It's the tendency to rely too heavily on the first piece of information received, the anchor, even when subsequent data contradicts it.
Can you give an example?
Sure. A patient initially complains of a specific localized headache pain. The doctor might anchor the entire workup on neurological causes, even if later information, like nausea and muscle pain, points much more strongly to a systemic viral illness. That first piece of data just sticks.
And this ties directly into the framing effect, or what's also called diagnostic momentum.
Yes. This is the risk of accepting a diagnostic label that was attached earlier in the process by the triage nurse, the referring physician, the ambulance crew, without independent verification. That initial frame gathers momentum, making it harder for subsequent clinicians to question it.
The classic example is the patient handed over as a probable simple gastroenteritis.
Right, and that framing makes the new doctor look for symptoms that confirm GI issues, rather than pausing to question if the patient's subtle low blood pressure might actually point to something far more serious, like sepsis.
So how do you fight that?
A powerful debiasing strategy for framing is simply maintaining healthy skepticism. You have to mentally restart the diagnostic process from scratch. You ask yourself, if I hadn't been told that diagnosis, what would I think now?
And these two biases often lead to premature closure. This is the failure to explore other possibilities once a convenient or satisfying diagnosis has been reached. It's a fundamental rush to judgment.
Premature closure is the enemy of safety. It's the cognitive pathway that causes a doctor to see a patient with cough and fever, label it bronchitis, and fail to look at the chest x-ray that might clearly show a pneumonia. The brain stops searching once a satisfactory pattern is found.
Next is availability bias. This occurs when we overestimate the probability of a diagnosis because it's easily recalled.
Yes, either because we've seen it frequently or because it was recent and memorable. If a doctor has just attended a lecture on a rare autoimmune condition, they might unconsciously start to suspect that condition in every patient with vague symptoms for the next week.
Or it's the peak of flu season, and every patient with a mild fever is immediately filed under flu.
Exactly. Potentially missing a life-threatening bacterial infection. Our intuition is distorted by the most recently or easily available examples in memory.
We also have ascertainment bias, often tragically manifested as the psych-out error. This is seeing what you expect to see.
And the psych-out error specifically targets patients with known psychiatric conditions or chronic pain syndromes. The risk here is that when they present with a genuine new medical problem, say abdominal pain, the clinician prematurely attributes the symptoms to the patient's existing mental health condition,
Resulting in a dangerously inadequate exam or investigation.
The doctor sees a psychiatric patient who's acting up rather than a person with a genuine acute medical emergency.
And the close relative is search satisficing.
It's a combination of satisfy and suffice. You stop searching for the best diagnosis once you find a convenient possibility that seems to fit the pattern. It's cognitive laziness, really.
You find the first zebra, and you stop looking for the giraffe.
When the giraffe might have been the correct answer all along, it avoids the effort required for a systematic type 2 review.
Finally, let's briefly consider the biases related to action versus inaction. Omission bias.
That's the tendency toward inaction, often justified by the principle of first, do no harm. If an adverse outcome occurs through a natural disease progression, it's sometimes perceived as less clinically acceptable than an outcome attributed directly to an intervention taken by the team.
And the opposite is commission bias.
The tendency to act rather than wait, driven by the belief that good can only come from doing something. In clinical care, recognizing which mode the brain is defaulting to is vital for mitigating risk. The expert thinker anticipates the situation where their bias is likely to manifest and applies the brake.
So recognizing these powerful biases is the necessary foundation. Now we need to discuss the practical strategies, the systems, and the internal mental tools used to mitigate these inherent human limitations.
And then this brings us squarely into the realm of human factors.
Okay.
Human factors is the science dedicated to adapting technology, environment, and communication to the reality of human limitations. We know that in high-stakes environments, most serious adverse events have poor communication or procedural flaws at their core.
And this is because type 2 thinking, that slow analytical mode, is easily crushed. We need high cognitive resources for it.
Right, and research shows convincingly that factors like severe fatigue, constant interruptions, cognitive overload, time pressure, and high stress severely degrade the brain areas needed for type 2 processing.
So when those resources are depleted, the brain is forced to revert to the less effortful type 1 processing to conserve energy.
An error spike. The environment must be designed to support safe decisions even when the clinician is functioning suboptimally.
This is why we rely so heavily on systemic strategies, like standardized communication. One of the most successful, mandated by organizations like the UK's Patient Safety First, is the SBAR structure for handovers and referrals.
SBAR. It's a mnemonic designed to force structured communication. Situation, background, assessment, and recommendation.
The situation have to be a crisp, immediate statement of what's happening, the emergency, the vital signs, the specific concern.
Right. Then the background provides necessary context, patient age, history, reason for current presentation.
Assessment is the current vital data, the latest signs, blood results, imaging.
And the recommendation is the explicit request for action. I need you to come review this patient, or I think we need to escalate to ICU.
The genius of SBR is that it acts as an external cognitive aid. It forces the communicator to process the information through the type 2 filter and prioritize what's essential.
And crucially, it ensures the core purpose of the communication, the recommendation, is never buried or forgotten due to communication chaos. It dramatically reduces the potential for systemic error.
Beyond communication, we use external decision aids that inherently fight intuition. You mentioned clinical prediction rules.
Yes, or CPRs. These are statistical models derived from large data sets that structure the diagnostic process.
And their primary benefit is consistency. Studies repeatedly show that these simple statistical models, when applied correctly, often outperform individual experts because they are applied without bias consistently every time.
They force a scientific, structured assessment to develop a numerical probability estimate, a process which is difficult for type 1 thinking to corrupt. Excellent examples include the Wells score for calculating the pretest probability of a DVT or a pulmonary embolism.
Or the CURB-65 score for stratifying risk in pneumonia management.
Exactly. They ensure the critical factors are weighed objectively.
Now, moving to personal internal strategies, we start with deliberate practice. And we need to be clear. Simply having experience for many years is not sufficient for true expertise.
Absolutely not. High performance in any field requires effortful practice, consistent coaching, meticulous feedback, and the dedicated ability to plan, assess, reflect, and adjust performance based on outcomes. Merely doing the job doesn't make you an expert. The commitment to reflective improvement does.
And that leads to perhaps the single most accessible and powerful debiasing strategy, reflection or enhanced metacognition.
Research confirms that consciously engaging in reflection during a decision-making process improves performance, particularly when the case is complex or ambiguous.
And that reflection manifests as deliberately pausing your automatic type 1 processing to ask two critical questions.
What is the evidence for this current appealing diagnosis?
Oh, yeah.
And what else could it possibly be?
That pause directly works against anchoring, premature closure, and search satisficing by forcing a systematic review and a search for disconfirming evidence.
Another powerful technique is synthesizing data into a concise problem representation or problem list before generating a differential diagnosis. For instance, rather than listing 15 symptoms, the clinician condenses it to a single focused statement.
Like a 30-year-old female smoker presenting with acute onset of pleuritic chest pain and breathlessness post-flight.
That synthesis step is incredibly valuable because experts spend more cognitive time defining the problem structure than novices. This organization helps retrieve relevant, deep knowledge from long-term memory and actively combats the initial bias caused by the patient's narrative sequence.
We also use systems like mnemonics and checklists to offload reliance on fallible human memory.
Especially when under the cognitive stress that impairs type 2 thinking. ABCDE for critically ill assessment, airway, breathing, circulation, disability, exposure is a universal success story.
And finally, we rely on red flags and the Rolobius principle.
Rouse rule out worst-case scenario. These strategies are explicitly designed to counteract the brain's desire for premature closure by forcing the consideration of dangerous yet possible diseases that may present with common benign symptoms.
So if a disease is rare but potentially fatal, like a pulmonary embolism, and the risks associated with the treatment are relatively low.
Rouse dictates you must investigate it until it is reliably ruled out, even if the pretest probability is low. This provides a crucial safety net against biases like the framing effect or omission bias.
Let's pull all these concepts together now, using a detailed look at the clinical challenge of suspected pulmonary embolism, or PE. This case demands the application of probability, vigilance against bias, and structured decision-making.
Our patient is a 25-year-old woman presenting with right-sided pleuritic chest pain and breathlessness. She recently recovered from a viral upper respiratory infection, and critically, her only medication is the combined oral contraceptive pill.
Okay, and her vital signs are completely normal, her physical exam is also normal, but the suspicion of PE is raised.
Right. So, step 1, pretest probability. We anchor on the prevalence. PE in a healthy 25-year-old is low. We then adjust for the risk factor, the oral contraceptive pill, which significantly increases the risk of venous thromboembolism.
So to structure this, we use the modified Wells score.
Yes, and even with the risk factor of the pill, if we only assign points for the criterion that PE is the most likely diagnosis, her score might be 3, placing her firmly in the low probability category.
So we have a low pretest probability. The Right-of-West principle dictates we must rule out PE because it's fatal and she has risk factors. So our next diagnostic step is often the D-dimer blood test. Let's imagine her D-dimer is raised at 900, where the normal range is less than 500.
Okay, now we apply the math of testing. The D-dimer assay is famous for being highly sensitive, at least 95%, often higher. This means it is an excellent test for ruling out PE.
So if the D-dimer had been negative, we could have comfortably relied on that high sensitivity and the low pretest probability to send her home, having reliably excluded PE.
Exactly. We would have been done. But it is positive. Now we must consider its low specificity. The D-dimer test is simply measuring fibrin degradation products, which are raised by any inflammation, trauma, infection, or recent surgery.
Including her recent viral infection.
Exactly. So we're dealing with the classic false positive scenario.
So applying the principles of Bayes' theorem, the positive D-dimer does not mean she has PE. It only means we have failed to exclude it.
And that a positive result is far more likely to be due to her recent viral infection than the rare PE. This is where the treatment threshold and Rouse intersect. Since PE is potentially catastrophic, and the risks of giving a temporary blood thinner while awaiting definitive imaging are low.
The Rouse principle dictates we must proceed with further, more specific imaging. The diagnostic test will change the management, justifying the subsequent investigation and the temporary low-risk treatment. Now, let's actively revisit the cognitive traps. Imagine this patient was initially seen in a busy clinic, and the primary doctor noted, recent URI, normal physical exam, likely viral pleurisy. And that label was handed over to the emergency room doctor.
Okay, so that immediately triggers the framing effect and anchoring. The ER doctor, under extreme time pressure, might anchor on viral pleurisy.
And they'd be looking for evidence to confirm that benign diagnosis, the normal vitals, the recent viral illness, rather than actively searching for disconfirming evidence.
Like the elevated D-dimer or the oral contraceptive pill history.
And this often leads to search satisficing. The doctor has a convenient answer that fits the common pattern. Why spend the cognitive effort to rule out the rare zebra?
The doctor fails to pause and apply metacognition. It takes that conscious effort, the type 2 break, to ask, is the normal exam truly sufficient to exclude PE? The answer is no, because PE often presents with a normal exam. And then, what is the worst-case scenario that fits the beta, PE?
The systematic application of the Wells score and the explicit calculation of risk forces the shift from intuitive type 1 thinking to systematic type 2 analysis.
And finally, we must close the loop with shared decision-making. After all the rigorous science and psychology, the clinician has to communicate the risks and benefits of the required CT scan or the temporary blood thinner clearly to the patient.
And our sources emphasize that clinicians must be extremely careful with risk communication because patient perception is influenced by irrational factors.
Right. When conveying statistics, whether it's the 2% chance of PE with a positive D-dimer or the risks of a procedure, we must use consistent denominators.
So instead of saying stroke is rare, we should use consistent numbers. Out of 100 people who have this procedure, 90 will feel much better, but 1 will suffer a serious complication and 2 will experience a mild side effect.
Using consistent denominators helps the patient truly compare risk versus benefit without relying on vague language. In the end, if the imaging result is subsequently reported as no pulmonary embolism, combined with the low pretest probability, PE is reliably excluded.
And the clinician can now safely confirm the ultimate diagnosis, viral pleurisy or musculoskeletal pain, and convey that diagnosis clearly, along with essential safety netting advice.
Emphasizing when and why they should immediately represent.
It's the combination of discipline, data gathering, probability calculation, systematic cognitive aids, and clear communication that safely and reliably navigates the ambiguity of the clinic. What an extensive look into the highest functioning area of the human mind under pressure. We moved from defining the profound problem of diagnostic error through the critical math of testing, unmasking the prevalence trap and the mechanics of Bayes' theorem, and finally into the psychology of our fast, intuitive type 1 brain and the errors it inevitably generates.
And the overarching final takeaway is this. Good clinical decision-making relies not primarily on collecting more information, but on constantly monitoring your mode of thinking. It's about recognizing when type 1 is running the show and actively employing systematic aids like SBAR and prediction rules alongside personal debiasing strategies like metacognition.
So knowledge and experience alone do not eliminate error.
No. Disciplined self-reflection is the mechanism that protects the patient.
And here is the provocative thought for you, the listener, to chew on. Studies show that the tendency to engage in that reflection during decision-making, that ability to pause and ask, what is the disconfirming evidence? What else could this possibly be? Is independent of a person's baseline knowledge, intelligence, or even their raw cognitive ability.
It's a separate, learnable skill divorced from natural intellect. So we ask you, how often in your own high-stakes personal or professional decisions, when you're negotiating a salary, hiring a team, or making a massive financial choice, do you consciously interrupt your fast, intuitive processing to apply that metacognitive break? Do you actively seek out the data that disconfirms your preferred hypothesis?
That is a skill worth practicing, whether you're in the clinic or the boardroom. That's all the time we have for this deep dive. Thank you for joining us. We encourage you to continue exploring the science of your own thinking.
Until next time.